Ptosis. We are going to talk about whether the ptosis is caused by levator weakness or the ptosis is because of Horner's syndrome. Two muscles elevate the upper eyelid. The levator, which is the major elevator and is supplied by the oculomotor nerve, and the Muller's muscle, which is supplied by the sympathetic chain, and this is an accessory elevator of the eyelid. Sympathetic denervation leads to Horner's syndrome. The first difference between ptosis caused by levator weakness or Horner's syndrome is complete ptosis caused by levator weakness and partial ptosis, which is caused by Horner's syndrome. Because Muller's muscle is just an accessory elevator, this will lead to partial ptosis. So this is partial ptosis, while levator weakness will give you complete ptosis. Therefore, in patients who are having weakness of the levator, they have complete ptosis and their line of vision is obstructed, while in those with Horner's syndrome you have partial ptosis and therefore the line of vision is not obstructed. Patients with Horner's syndrome, the ptosis abates when the patients look upward, and therefore this is a correctable ptosis. While in those with levator weakness, the ptosis is usually not correctable. Again, this is because the ptosis is more complete. The third one, which is an important sign, is reverse ptosis in Horner's syndrome. The sympathetic chain also innervates the lower eyelid. Denervation of the lower eyelid leads to an upside down ptosis in the sense that the lower eyelid will still cover the cornea when the patient looks upwards. The patient is looking upwards and you can see that the lower eyelid is still touching the cornea, while in this eye there is a free space and therefore you can see the visible sclera on this eye compared to this eye which has Horner's syndrome. The fourth one is in Horner's syndrome you may have miosis, anhydrosis, and enophthalmos. In fact, they are only present in a minority of patients. The fifth one is frontalis contraction or frontalis hyperactivity. This is a compensatory mechanism which occurs due to obscuration of vision in complete ptosis, and therefore you will expect this in patients who are having weakness of the levator. So if you can see over here, there is frontalis hyperactivity in this patient who is having complete ptosis, let's say due to a third cranial nerve palsy. You will not expect this to find in patients with Horner's syndrome. So you can see the frontalis muscle over here. There is hyperactivity, and you can see that the eyebrow of this patient is lifted. This is a compensatory mechanism in patients who are having complete ptosis. Therefore, it's important to distinguish that the patient has ptosis because of a levator weakness, which could be due to a third cranial nerve palsy, or is it a sympathetic denervation, let's say because of a Horner's syndrome.